let's talk a little about your practice, sir. What kind of patient base you have?
I am a director of Manish Eye Institute. Our aim of the institute has to a patient-centric approach for each and every patient.
What is your real passion amongst all these?
My whole journey of the life is inside the lens. So my real passion is the cataract and refractive surgery.
How do you really customize the lens for a patient?
I am never pushing the premium lenses to the patient. We always go all the thoroughly examination at our center.
तो आप पेशेंट को एडवाइस करने से पहले क्या इम्पोर्टेंट टेस्ट्स या इन्वेस्टिगेशंस करना चाहेंगे जिससे आपके पेशेंट को बेस्ट पॉसिबल आउटकम मिले?
We check thoroughly about the different layers of the eye. तो आप जहाँ भी ऑपरेशन कराना चाहे और अगर आपका कंसल्टेंट बोल रहा है कि ये टेस्ट आपके लिए सही है तो ही आपको उस लेंस के लिए जाना है.
How do you really ensure that you get consistent and perfect outcomes in these cases?
When we consider the long eyes or very long eyes, when the actual length is more than 25 or 27, 26.5, then we always cross check with the HEAL RBF formula version 3.0. So it gives very good idea about the customization of the lenses.
Hello and welcome to another engaging episode of the Eye Conversations with me, your host, Dr. Sheetal Brar, Director ProSight Eye Hospital, Chandigarh. So by now, I'm sure you all already know that Eye Conversations is a lively and vibrant space where we sit down with prominent ophthalmologists of India who share their expertise and knowledge and help us educate about eye diseases and eye care through innovative and dynamic approaches. Joining the list of our stellar guests, today we have none other than Dr. Twinkle Shah from Ahmedabad, India on Eye Conversations. He is the medical director of Manish Eye Institute at Ahmedabad and runs a highly successful, high-volume, super specialty ophthalmic practice in the region. With a keen interest in modern cataract surgery and IOL power calculation, he brings expertise to eye care and a passion of delivering the best possible outcomes in every single case of cataract surgery. Wow, sounds like a magician. I'm so excited to start this conversation with Dr. Twinkle Shah today. And ladies and gentlemen, let's dive into the episode right away without wasting a single minute and welcome Dr. Twinkle Shah to Eye Conversations. Welcome to Eye Conversations, Dr. Twinkle Shah. We are so honored and excited to have you on our show today.
Thank you, Dr. Sheetal, to inviting me. I am very much thankful to Mr. Sarad and BVI team to inviting me on your Eye Conversation.
So, sir, before we start with our conversation, I'm sure not just me, but everyone in the audience is a little curious about your name. How did you get your unique name, Twinkle?
Yeah, there is some history behind it. According to our Indian custom, so my aunt kept my name as a Manish and my father kept my name as a Twinkle. So I think I'm age of 58, so I think I am the first Twinkle in the India. So
Yes.
whose name is a Twinkle, because people are knowing the Twinkle Khanna and other Twinkles, but all are the female version of the Twinkle, but I am the male version of the Twinkle at the age of 58.
Exactly. So when I was searching information about you on AI was suggesting me Dr. Twinkle. She is an expert in ophthalmology. She brings expertise. So everything related to a female was...
Actually, you should find out as not as a Dr. Twinkle. It's my actual name is a Twinkle Kumar. So you have to go for the Twinkle Kumar Shah for the searching in the Google.
Okay. That's interesting. Yeah, I was also wondering that you are Twinkle and your clinic's name is Manish.
But actually, we both are the same personality. The Manish and the Twinkle is the same name for me.
Wonderful. So let's start our podcast now, sir. I would just like to know about your early journey in ophthalmology and what really inspired you to become an ophthalmologist.
Yeah, it's a long way back journey. When I was in a medical school and I have a first rotation in the second year of MBBS in ophthalmology, and that was my first rotation. And I see how at that time the microsurgery era was just emerging up, and only two specialties were coming with the microsurgery. One is the ophthalmology, and second is the neurosurgery. And when I went to the clinics, I see that the ophthalmology is a branch where it's like a medicine branch. It has a microsurgery. It is a cutting edge technology. I seen the people were working on the microscope or trying to adjust with the microscope. So it fascinated me that this is something new and something unique which is happening in the uh, medical field.
Yeah.
So at that time, I love in come in interest for the ophthalmology. And when I got admission in ophthalmology, I reject all other admissions of the. I was able to get the other orthopedics and surgery in the merit system, but I opted for the ophthalmology. And after so many years, I feel that it was my right decision.
Great, sir. Uh, with me, actually, it was quite the opposite. I took ophthalmology because my family wanted me to take ophthalmology because for a female, I think it gives you a good balance between work and life and also OPD and surgery. But I really did not find it very interesting in the first year of residency because as first year resident, you were not really allowed to see patients' findings, not even use a slit lamp for that matter. And you're just writing notes. So I was not really very happy when I took ophthalmology as my career. But yes, from the second year onwards, as I became senior, I started seeing the findings on slit lamp, on indirect ophthalmoscopy, started treating patients. And that's when I really developed interest in this field. Okay, so was there a defining moment or any mentor who shaped your career in ophthalmology?
Yeah, I am lucky in that way. I have three main mentors in my life, and they all are very renowned ophthalmologists of the world. Uh, I have a mentor, Dr. Nagpal, who taught me how to communicate with the people.
Very nice.
So he teach me, and I seen him how he's uh, talking to the patient very empathically and very transparently talking about the disease and very transparently talking about the complications which are arising after retinal surgery. So that teach me very well how to communicate with the people, and also I learned from him how to communicate with the colleagues, how to communicate with the seniors, or how to communicate even the at that time the males were there, so how to communicate international level of the males. So he's my mentor as far as the communication skill which I have developed over the years. My another mentor, Dr. Abhay Vasavada, uh, mm, he taught me how to remain with the latest advancement in the and how to implement all this technology in the our day-to-day practice. And very seamlessly, he has developed his practice the same way I follow to him in that way about the remain in attached with the latest developments and advancement. And another tip which I got from the Dr. Vasavada is the learning has never end.
Certainly.
So I'm still learning at the age of 57, 58. So I'm very much happy with him. And my third mentor, Dr. Shranik Shah, he initial phase of my practice, he taught me how to remain an ethical. Even you have a high volume surgery or even you are a very big name on the society ground, but how to be remain empathetic and how to be remain grounded in your practice with maintaining the uh, ethics. So I'm very much grateful to all my three mentors. So what I am at present, that is a blessings of them.
Certainly, sir. It's so nice to have the blessing of some of the most renowned and iconic ophthalmologists that we have today. And you have imbibed some of the best skills like communication skills, staying updated with the technology, and learning empathy from them, which is helping you so much today.
Yeah.
So let's talk a little about your practice, sir. Can you tell us where exactly it is located and what kind of patient base you have?
I'm a director of Manish Eye Institute. Institute is at the Paldi area of the Ahmedabad. We are catering all the patients across from the Gujarat. We have all the urban societies patient. We have a rural areas patients are also coming to us. We have a pediatric age group to geriatric age group. So many patients are there, which we are catering. And our aim of the institute has to a patient centric approach for each and every patient. So it's a high volume institute, but we are each and every patient is giving equally respect at our place.
That's so nice and inspirational, sir, that you are serving every kind of sector of society and treating all patients of all ages. And I believe yours is a super specialty hospital and institute. And you have not only just cataract and refractive, but also glaucoma, retina, and uvea clinic, which is actually quite rare. Not many hospitals have super specialties like uvea. So it's really impressive, sir.
Yeah. Thank you, Dr. Sita. It's like that we are having a in depth all the diagnostic and therapeutic approach for all the disease of the eye. Uh, as far as let's take as an example that for the cataract, so we have a very good diagnostic from the very advanced optical biometry to measure the intraocular power. We have very good phaco machines like a Centurion Gold machine, which with a active sentry handpiece, where we can deliver the best phaco technology which is available at present in the world. We have a machines like uh, uh, image guided system, where we can give a very precision in our torics and premium lenses. The same way in the glaucoma, we have all the diagnostic from the perimetry to the OCT, and we have all the therapeutic way. We have a SLT, we have a laser, YAG laser for the iridectomy. The same way for the retina, we have all the advanced technology for the diagnostic and management point of view. So we cater the oculoplasty. We have our own neuro-ophthalmology department. We have our uveitis clinic. Recently, we had started our myopia clinic also. We have a system where we can go for the low vision aid system also. And vision therapy center is also with us. So all kind of the disease. So yes, actually our institute is a one-stop for all ophthalmology problems. And that is our main aim to have run this institute. That is a one-stop solution for these all the ophthalmology. We do the keratoplasties also. We do the collagen cross-linking also. We do refractive surgeries also. So it's a one-stop solution for at our hospital or our institute.
That's so amazing, sir. And really nice to know that you're treating all possible varieties of eye diseases that people can have, and treating like corneal diseases, doing keratoplasty. So everything. So this really requires access to eye banks and specialized facilities which you have acquired in your practice. So I'm sure this is helping a lot the people of your region. I also want to know that do you also have oculoplastics and artificial eye
Yeah, we do oculoplasty
and
for
the
all the
prosthetic
leads.
eye?
Yeah, we do all the lead surgeries. Even we do the excentrations also. And
So people who are
yeah,
left with
prosthetics, ocular prosthetics also.
yeah.
Even after the corona era, all these patients who have undergone the mucormycosis and they have the ocular excentrations, we are putting implant for them also. The maxillary implants and all this work at my place.
That's so amazing to know, sir, that you are treating so many varieties of eye diseases and eye problems, and you have all the specialties available with you. So it's truly an institute because a lot of practitioners, they write the hospital as an institute, but generally they're mainly catering to cataract and refractive surgery, at the most glaucoma and retina. But you have the other specialized branches also, such as the uvea and ocular prosthetics, which are quite rare with the private hospitals. So that's truly amazing, sir. And
Thank you.
I would want to know that even though you have so many specialities, what is your real passion amongst all these?
My real passion is the cataract and refractive surgery, and particularly my more focus on the cataract surgery because I believe I am living in the lens. So the my whole journey of the life is inside the lens. So I always passionate about the how to deal with the different kind of cataracts from small pupil cataract surgeries to the posterior polar cataracts and
All the
all the
complex
complex surgeries. And also
cataracts.
I am keen interest about the intraocular lenses and how this
Wonderful.
technology progressing about the intraocular lenses, about all the advanced lenses. So rather than just keeping the lens inside the patient's eye, I always focus on which technology they are incorporated for the multifocality, which for the EDOF technology. So I want all the 6 or 7 varieties of EDOF, which how this lens works. Suppose the VVT, the how it works in the patient's eye. What is the basic optical principle of the VVT? The same way, suppose if we take the isopure, so how the isopure works as a advanced monofocal.
True.
So take like a fine vision lenses. So how they are creating the multifocality or trifocality in the patient's eye in the optical system, and how it works with the patient. So all these systems I analyze very thoroughly. So this is my passion also.
Very inspirational, sir. And I feel that as a practitioner and as a surgeon, it's so important to first understand the basic principles behind all these technologies, the modern lenses, yourself well, because only then you will be able to counsel your patients properly, tell them about the benefits and the limitations of every technology. And that, I believe, goes a long way in winning the trust of your patients.
Yeah, absolutely.
And more so, this is so important for modern practitioners these days to understand the science and the technology behind these modern technologies, because the needs and lifestyles of our patients are changing today. Most of our patients are using now functional intermediate vision because their activities are related to intermediate vision nowadays. They're using mobiles, laptops, tablets, even our elderly population, right?
Yeah.
So, since our needs are changing, our patients' lifestyles are evolving, so we as practitioners also need to evolve and adapt to new technologies.
Yes, absolutely. And fortunately, so many companies like Alcon, BVI, J&J, all these are offering us very good lenses in their our armamentarium. So we can give the patients very good options, and
Yeah.
we select the patients. We thoroughly examine the patients and which is the exact requirement of the patient, and we
True.
customize according to
Yes.
the patient's demand, because we have so many choices.
Yeah. So it helps us to tailor and customize the treatment for every patient and every individual eye
Yeah,
to give the
absolutely.
best possible outcomes.
Absolutely.
So this brings to my next question, which is, how do you really customize the lens for a patient? Let's say you have a patient who is a housewife, who likes to read a lot and is also doing a lot of kitchen work, does not drive. And on the other side, you have a patient who drives a lot in the night and is also into reading. So how do you really customize the technologies for them?
When I'm customizing, I'm not only I'm never pushing the premium lenses to the patient. We always go all the thoroughly examination at our center. So first we start from the ocular surface, whether the patient's ocular surface is fit for the any kind of the multifocality or not. Whether if it is okay, then we go for the upper optical biometry. We check the what is the optical biometer, which are the parameters for the front corneal surfaces. We go for the topography of the patients. We see the smoothness of the cornea, whether the multifocality is acceptable by the eye or not. The optical system of the patient is very important for us when we are considering the patients. Then we come to the patient's need. What is the patient's need? How the patient is working pattern is there, how much time they are spending for the reading, how much time they are spending for the driving, how much times they are spending for the on the electronic gadgets. According to that, we discuss with the patient, and then we offer to the patient that, suppose as you have asked me about the patient usually she is not driving and she has to do all the other kitchen work and other work. So we ask them to go for the fine vision type of trifocal lenses. Or with the patient which you had asked me about, the night drivers, and they also read a lot. In such patients, or particularly they are working on the laptops or computers, or all newer executives who are coming at the age of 45 or 50, they are coming with the cataract or early posterior subcapsular cataracts. We offer them for the EDOF type of lenses. Or sometimes we have to give the isopure type of lenses where you have some kind of intermediate vision there, so they can do their daily activities very well.
Yeah, and these lenses, in my experience, also provide excellent quality of vision without any compromise and any side effects like halos or glares. And in my experience, I've also used the fine vision trifocal lenses and various other types of lenses as well. And in even in patients with the where we do a RLE or refractive lensectomy, these lenses do provide complete range of vision, and the compromise on the vision, the quality is not really so much, and over time they adapt to the technology and they really enjoy the benefits of it, which is complete spectacle independence.
Yeah, absolutely.
सर, आप एक हाई वॉल्यूम प्रीमियम कैटरेक्ट सर्जन हैं एंड आप बहुत प्रीमियम लेंसेज डालते हैं जैसे ट्राईफोकल्स, ईडॉफ वगैरह। तो आप पेशेंट को एडवाइस करने से पहले क्या इम्पोर्टेंट टेस्ट्स या इन्वेस्टिगेशंस करना चाहेंगे जिससे आपके पेशेंट को बेस्ट पॉसिबल आउटकम मिले?
जब हम प्रीमियम लेंस का जब बात करते हैं तो वी हैव टू कस्टमाइज द पेशेंट, व्हाट इज द नीड ऑफ पेशेंट, एंड वी चेक थॉरली अबाउट द डिफरेंट लेयर्स ऑफ द आई। सपोज हमने पेशेंट का सबसे पहले हम ड्राई का वर्कअप कर लेते हैं, पेशेंट का फ्रंट का कॉर्निया का मैपिंग कर लेते हैं, टोपोग्राफी कर लेते हैं, पेशेंट का प्रिसाइज बायोमेट्रिक कर लेते हैं कि किस तरह से पेशेंट का ऑयल पावर जाएगा। देन वी चेक द रेटिना ऑल्सो, पेशेंट का मैक्यूला कैसा है, फंक्शनल विजन कैसा है, वो सब हिसाब से ये सब कंसिडर करके हम कंसिडर करते हैं कि ये पेशेंट को प्रीमियम लेंस डाल सकते कि नहीं डाल सकते। अगर डाल सकते तो कौन सा वाला प्रीमियम लेंस उसके लिए अच्छा रहेगा। जो मैंने बोला अभी वो सब टेस्ट हम आप नहीं कर रहे हैं, तो ऐसा हो सकता है कि आपने जो प्रीमियम लेंस सिलेक्ट किया है उसका आपको अच्छा रिजल्ट नहीं मिलेगा। तो आप जहाँ भी ऑपरेशन कराना चाहे, पहले ये एक बात जरूरी है कि ये सब टेस्ट होना जरूरी है, और अगर आपका कंसल्टेंट बोल रहा है कि ये टेस्ट आपके लिए सही है तो ही आपको उस लेंस के लिए जाना है।
Dr. Shah, you're a high volume cataract surgeon and you're doing so many varieties of complex cataract surgeries as well, such as post-keratoplasty cases, post-vitrectomy, post-refractive surgery, and of course the normal ones. How do you really ensure that you get consistent and perfect outcomes in these cases?
Yes, Dr. Sheetal, it's a very good question. When we go for the oil power calculation, our main aim is for the proper biometry and the oil power selection, formula selection. For the normal eyes, we always consider the Barrett Universal 2 formula, CAN formula, and EVO formula, EVO 2.0 version formula. We usually go for that, and our patients, we undergo the ESCRS online calculator. We take the readings of all 7 formulas. But my key for the normal eyes is the Barrett Universal formula, CAN and EVO 2.0 formula. When we consider the long eyes or very long eyes, when the actual length is more than 25 or 27, 26.5, then you always cross-check with the IOL RBF formula version 3.0. So it gives very good idea about the customization of the lenses. And particularly, I will be very cautious when there is a short eyes, particularly when the actual length is 22 or the less than 21. In these cases, we always cross-check with the offer QST formula, and also we also cross-check with the ray tracing formulas to have a better comparison, and where according to our surgical experience we analyze and we select the oil power for these patients. As far as you talk about the complex cases, particularly when we consider the patient who have undergone the refractive surgery, so we thoroughly check about the what is the keratometry, how the keratometry's reading has been taken by which machine, the zone of the keratometry, 3 mm zone, 4 mm zone, patients, what is the patient mesopic pupil size, and according to zone we select our IOL power. So we first do a proper keratometry finding. So we use that keratometry for the average keratometry value.
Okay.
And the second important part is the formula is concerned. We see the topography, whether the regular surface is or not. If patient has been operated with a very good regular surface and patient has a aspheric ablation has been done, then we go for the good premium IOL also in such patients. But if patient has undergone the irregular surfaces or patient has eccentric ablation is there, in such patients we usually go for the formulas which are non-cornea based, like a Prisoner's formula, or we go for the Olsen retracing formulas.
So you are an expert in biometry and you are running a very successful course in biometry and IOL power calculations at the All India Ophthalmic Society conference for the past 15 years, I believe.
Yeah.
So that clearly shows that you have in-depth knowledge in this very complex topic, which is biometry. So अब हम बात करेंगे little bit about this area of your expertise, which is the IOL power calculations. So I understand that IOL power calculations can be a tricky thing for any ophthalmologist, especially in complex cases. So would you like to break it down for us? How do you do your biometry and IOL power calculations for normal eyes versus the complex eyes?
Thank you, Dr. Sheetal. Very good questions. As far as normal eye is concerned, in IOL power calculation formulas, we usually follow the Barrett Universal 2 formulas. But even though we always go for the ESCRS calculator, we cross-verify all the 7 formulas which are given on the ESCRS calculator. We compare it accordingly for the normal eyes. Particularly, I will tell you about the short eyes and the very short eyes and the long eyes and very long eyes. When we are considering the long eyes, we also cross-check verifying with the Barrett Universal formula with the CAN formula and EVO20 version formula. And particularly in very long eyes, we also take a help of Hill RBF version 3 formula. Particularly in short eyes, we also take in consideration of the offer QST also, and sometimes we also consider the because we have a tomographic analysis of the cornea, so implement the ray tracing formulas for the calculation of these short eyes IOL power calculations. So particularly we have accessibility of the oculics and the Olsen formulas. So we compare with the ray tracing formulas in short eyes also.
Wonderful, sir. But would you like to guide those ophthalmologists who do not have such high-end technologies and equipments, like you said, you have the oculics and the high-end optical biometers. So those who have basic biometers and basic technologies, how they can improve their results? Would you like to guide them?
See, at present era, when we are going for the selecting for the premium IOL, then our first concern is the optical biometer, because everybody has that in their mind that the optical biometer only gives the better readings, but it is not so. Whatever the excellence you are measuring with the immersion scan, and if you have selected your proper scan in immersion scan, that data is also validated with data for the IOL power calculation is concerned. So in such cases, you can put all this data in ESRS calculator, you get all these 7 formulas which is available to you. So you have to access internet accessibility, which is everywhere is available. So even though you don't have any hi-fi gadgets, or you don't have a topography or tomography and swab source based OCTs or whatever you optical biometries, so you can go for these simple gadget, which is a gift from the ESCRS to across the world.
Perfect, sir. This was the response I was looking for, because a lot of ophthalmologists still do not have these high-end technologies and struggle to get a good biometry and also want to do a premium practice. So I think the online formulas these days have made our life so easy and simple. And even in the most complex cases, like the post-refractive surgery cases, post-keratoconus cases, these formulas are really helping ophthalmologists all over the world. Nowadays, we see so many people undergoing different kinds of laser refractive surgeries like PRK, LASIK, and recently SMILE. And eventually, over the next 2 or 3 or 4 decades, they are going to show up for cataract surgery. What is the protocol that you follow for IOL power calculations and biometry in these cases?
Yeah, very good. Because it's not now, but since last 25 years, people are undergoing the refractive surgery, and now these patients are coming to us for the cataract surgery. And all these patients, we undergo all these basic workup which we have already discussed before. But particularly for me, I am more focusing on the corneal regularity or irregularity is there or not. Whether at that time the older machines were used for the refractive correction, so properly centric and aspheric surface is there or not for the selection of premium IOL. And as far as formula is concerned, the IOL power calculation formulas, we have a very good ASCRS calculator for the post-refractive surgeries, According to that, we have so many options on that, and my more focus on the Barrett one. Barrett 2K calculators is also very good working for these post-refractive patients. So these are the ways you can have a very good post-refractive eyes IOL power calculation. So it gives a very good results. Uh, as far as RK is concerned, so many times that we have a variable keratometry, and those patients we are always very skeptical to go for any high premium lenses in such cases. So usually we go according to the keratometry reading, and we usually prefer to constrain our staff for the monofocals or the toric monofocal lenses, avoiding the multifocality on those patients. And IOL power calculation formula is concerned, we follow what the ASCRS calculator is giving in the post RK patients. And in certain cases, we found that the Higgins help works better in the post RK patients.
Perfect answer, sir. Let's assume that we have a post LASIK patient whose cornea is fairly regular. There are not too many corneal abrasions, and the ablation is well centered. Now, in these cases, would you like to go for a trifocal lens or an EDOF lens or an advanced monofocal lens or just a monofocal?
Yes, absolutely. When there is a very good cornea, and particularly we patient who have undergone the refractive surgery and he do not have dry eye,
Yeah.
and the surface is absolutely very good, we can offer them the advanced monofocal or EDOF lenses, because the newer generation EDOFs are working very well, and these patients do not have loss of contrast sensitivity because they have already some loss of contrast sensitivity because of refractive surgery.
So,
And now we are giving them the trifocality or the multifocality. In such cases, the chances of decreasing the contrast sensitivity more. So newer generation EDOF lenses works very well in this situation. So we have started using the newer generation EDOF lenses and the advanced monofocal lenses in these good corneas.
great, sir. I totally agree with you. And I also follow the same principles in treating these eyes at the time of cataract surgery.
And Dr. Sheetal, you are also a refractive surgeon, and you are also doing so many refractive surgeries since last decade, and you have been known as a queen of the smile. So, what is your way of dealing this kind of a post-refractive surgery patients when they are undergoing for the cataract surgery?
Thank you, sir. So, my approach is fairly similar to yours, but I also like to compare 4 or 5 types of modern generation formulae for post-refractive surgery cases. And these formulae are the online ASCRS formula, then the Barrett 2K TK formula, and the Haigis-L formula, which is inbuilt in the IOL Master 700, and finally the ray tracing formula available in the MS39. So I look at the agreement of these formulae, and then finally decide my lens for the patient. And I generally like to err slightly towards the myopic side because all these patients are mostly post myopic, and they get good near vision, and you expect them to have good near vision when you select a slight minus target.
Yeah, absolutely. Fantastic.
So you operate on so many thousands of patients, and we understand that not every patient can be super happy after surgeries. There could be many reasons for patient dissatisfaction. I would really like to know from you what is your approach, and how do you really counsel these patients who have a different outcome, or the outcomes which do not align with their expectations?
The expectation part, we first consider all this expectation part comes preoperatively. So we start from the preoperative. We curtail the expectation of the patients from the day one they are entering to our counseling. So because they are paying very premiumly, they have all the expectation of a premium expectations. But in such patients, we always tell them that these are the human eyes. These are what the lenses are made, are not the God-made lenses. They are the human-made lenses. So can be a perfect what the God is making. As for example, suppose your lens power is 21.79. So I cannot put a lens of 20. There is no lens which is available for 21.79.
Exactly.
Either we have a lens of 21.50 or either we have the lens of 22. So we have to adjust that kind of a power, or a fine tuning is always required in such cases. As far as we thoroughly check and we thoroughly investigate when the patient has not the outcome what has been expected. So we again check how the ocular surface is there, whether any macular problem is there, and if everything is clear from our side, then we find out that it is a refractive surprise. Then we talk with the patient very empathically, how to deal with this kind of the refractive surprises. We tell them the other options which is available by the laser corrections or the piggyback lenses or the IOL exchange. We discuss with them the pros and cons, and if you remain transparent in such situations, the patients are usually accepting it very well. So all the expectations we are curtailing in such a way that we give them the tailor-made situations, that how to manage these expectations or surprises.
Yeah, that's so important these days, being transparent with the patient and having an open discussion with the patient about their outcomes, and just in case something does not align well with their expectations, being with them and helping them with the, let's say, secondary surgeries or any other technology that might be needed to make the outcome perfect.
Absolutely.
Okay, sir. So now we come to the fun part of this podcast, which is the rapid fire round. Okay. So when you're not in OR, what is the hobby that you like to do to unwind yourself?
I'm very much passionate about the ophthalmology. So my day starts from 9 to 9. So there are some situations where I get more time, and then my first priority is my family, and I go for the family time spending. That is my first priority. And the second part is I have a hobby of reading. I'm fond of reading. So I all these reading. I'm reading of autobiographies. I read a lot about the spiritual upbringing.
Nice.
So that is my second hobby. And I do yoga. I do regular cycling. So my daily activities start with the other activities also. I do swimming also at the twice or thrice in a week. So all these things going on and on and on. And second, another thing, I am keen to travel a lot. So and my interest is to explore the unexplored places. So I have seen so many unexplored places of India and across the world. So that is my hobby.
Any funny or memorable incidents or patient that you can recall and you would like to share with us?
So many memorable instances. Just I will tell you a week before incidents. एक पेशेंट का ऑपरेशन हुआ. हमारे यहाँ सिस्टम ऐसा है कि पेशेंट कुछ गलती ना कर दे, इसीलिए हम पेशेंट को पोस्ट ऑपरेटिव स्टीरॉयड एंटीबायोटिक कॉम्बिनेशन के 2 ड्रॉप वहाँ से ही दे देते हैं. सो as per protocol, it was explained that you have to put this drop 2 hours early, and the very next day when patient came for the follow-up, he kept 2 empty bottles in front of me that दवाई खत्म हो गई. So it was very surprise for me that how it is possible कि आप दवाई कैसे खत्म हो सकती है. सिर्फ आपका ऑपरेशन रात शाम को 3 बजे हुआ है और अभी दोनों दवाई की बोतल खत्म हो गई. So I asked, आप दवाई कैसे डालते हो? तो the lady took the another bottle and opened it and put 8 or 10 drops in the palm. और ऐसा बताया कि हम ऐसे डालते हैं. So that was a very very funny situation
Really?
at that time. The another incident that I am just giving you very briefly. ऐसा ही एक पेशेंट का ऐसा हुआ था कि patient was a scleritis patient, and I gave the steroid very frequently and asked him to come again after 3 days. And there was no response at all, and that was a steroid of 1 hour early. So I asked him, how you are putting the drops? तो उन्होंने फिर बाद में काफी पूछने के बाद बताया कि वो मुंह में डालने की तरह वो ड्रॉप डाल रहा था. So many funny instances are happening.
I know, really. These are really funny incidences, and this really shows that how much ever you try to explain the patients, it's important to get the feedback from them and check whether they have understood the instructions and are actually putting drops as per the instructions or not. Very important.
After that instance, we have make that protocol. Every simple thing like putting an eye drop has to be trained very well to the patient. And that has also again changed in our protocols, that how to put the properly drops to the patient in the post-operative instructions.
Certainly. The phaco machine you love the most?
Centurion Gold with active sentry and piece. And preferably I would like to have image guided system.
Intraocular lens you would want to get in your own eyes?
Oh. Fortunately, at present, I don't have any cataract. If I have a cataract at this time, then I would go for the EDOF lenses, because being I am a low myopic patient, I am not using the glasses in my routine day-to-day activities, and so I would like to have some range of the vision for myself. And another, I'm keen not to lose the contrast sensitivity for my own eyes. So I would definitely go for the EDOF lenses at present scenario. Let's hope the over period of time when I get develop the cataract, and what will be the choice at that time.
Great choice, sir. Ahmedabad street food or fine dining?
I am a Gujarati guy and I love the Gujarati food very well. So all you must have heard about the gatia, dokla, khaman, and I eat a lot for that.
Great, sir. I also love Gujarati food a lot. One surgery you will never forget.
Actually, so many surgeries I never forget. But if you are asking me,
Like
I
it could
have
be a challenging case
yeah
that took your entire day, or something really.
yeah. Then
important.
one exhausting surgery which I remember, that a 42 years old guy, one-eyed patient. Patient has a subluxated brown cataract and very narrow angles. Patient has intraocular pressure was 35, and nobody was operating him because of the one-eyed patient and a subluxated brown cataract with the major pupil. So the surgery took me nearly 1.5 hours to finish it up, because I had to go for these pupillary dilators. I had the capsular retractions also, and CTR implantation, and so that was the night which I spent with so much tension, in particularly that case. And I was expecting the white cornea on the next day, and fortunately by wow effect, patient has 636 vision the very next day.
Wonderful.
So that was a nightmare surgery which I performed. That all the cataract complication was there in that particular one-eyed patient.
Yeah, as surgeons, we sometimes have to see these days, and these kind of cases teach us a lot also.
Yeah.
One surgical mistake that taught you something valuable.
Yeah, in the early days of my phaco career, initially we were operating with the machine which has a 3.2 millimeter incisions. And I was visiting one trust hospital, that I was visiting for 2 hours or 2.5 hours for that center, and we were operating 10 to 12 surgeries, even though at that time the machines were not so good. And in 1997 we upgraded the machine, and that machine from Opsys MMP to Universal 2, and the machine was rather than 3.2 incision, it was 2.8 incision machine. I finished all the surgeries very well, and come back, and very next day the optometrist on that center called me up that, sir, we have a 3 iris prolapse in our post-ops. Then I suddenly realized that this machine is for the 2.8, and I want 3.2 incisions in all these patients. So that give me the lesson that you should go for the very precisions, and we have to be very precise rather than for the time factor. And from that day, I stopped down the time factor in my surgeries, consideration of the time factor in my surgeries, and going for the quality work rather than time related works.
You've had so many mentors, sir, but could you name one surgeon whom you deeply admire?
Barrett, sir. I love a lot the way Dr. Barrett is working, the way he's innovating the things, he's giving the gift to the society. He's an amazing person. When we are meeting him, it's an amazing personality. So Dr. Graham Barrett is my iconic
agree, sir.
iconic person for me.
He's a trendsetter, and he's so innovative even at this age, and has given us all the modern IOL formulas, the Barrett 2K TK, the Barrett Universal 2. We all have learned biometry pretty much from him, and he's also innovated the extended depth of focus technology lenses.
Yeah.
So truly admirable person. So if you were not an ophthalmologist, who you would be? According to my nature, I would be either a technocrat or a researcher. That's all. But my passion is ophthalmology only, fortunately. But you said you read spiritual books also. Yeah, of course, but I want to become a guru for that. The last question. What is your guilty pleasure?
Yeah. Uh, my wife used to sleep at 10:30. And I'm fond of watching the all surgical videos on YouTube late night. So go on continuing the video watching 12:31, and then I feel a little bit hungry. I go down, have a scoop of ice cream or a 2 3 bites of the candies. Though I am a diabetic, the very next day I'm having a harsh readings from both the glucometer and my wife. So
Sir, you're telling this so sweetly, but I think you should not be so sweetly irresponsible.
yeah, of course.
Sir, with this, we come to the end of this fun segment as well as the end of this podcast.
Thank you, Dr. Sheetal, for inviting me, and thank you, Mr. Sarad and the BVI, to be a part of your AI conversation.
Thank you, sir, again for being part of Eye Conversations and sharing all your expert insights and enlightening us with your knowledge and giving us such wonderful tips as practicing ophthalmologists and even for patients how to take good care of their eyes. So thank you so much for coming to the Eye Conversations.
Thank you.
It was a pleasure hosting you on the show today.
Thank you, Dr. Sheetal.
So friends, I love this episode talking to Dr. Twinkle Shah today on Eye Conversations, and I hope you enjoyed this episode as well. So if you like our content, please follow us on social media handles, Instagram, Facebook, as well as YouTube, and give us suggestions and comments in the comment sections below as to how we can further improve and create. So stay tuned as we are coming up with a lot of exciting content and new celebrities on our show. Bye-bye for now.